Vanakkam. We've all heard of static procedures for correction of the claw in ulnar nerve palsy. Are they really useful? Can they be done? Where are they actually indicated? And how are they done? And are there any conditions where they should not be done? All these are discussed in this video. When we talk about the surgical management of ulnar nerve palsy, obviously the first line of treatment would be surgery on the nerve, and we have discussed this in another video which you can access by clicking on the icon above. There are situations where we cannot do a surgery on the nerve, so other procedures would have to be done on the hand to restore function, and these can be either static procedures or dynamic procedures. Before talking about the role of static procedures in the management of ulnar nerve palsy, there is a very important point which we must understand. If there is an ulnar claw, mortars are available and there is no contraindication, the best procedure would be a dynamic transfer even if the Bouvier test is positive. This is because dynamic procedures offer much more in the way of providing strength and function. Then what are the indications for static procedures? Multiple nerve palsies with paucity of mortars, or there are a few available mortars which may be needed for restoring more important function, or patients who are non-compliant for therapy after tendon transfers. Let us now see the guiding principles of these static procedures. In a claw hand, there is hyperextension at the metacarpophalangeal joints of the fingers. But when we stabilize the metacarpophalangeal joints in about 20 degrees of flexion, by holding them, the patient will be able to extend the fingers and the claw will disappear. This is the basic principle of static procedures. That is, the metacarpophalangeal joints of the clawed fingers are stabilized in about 20 degrees of flexion so that the patient can extend his IP joints comfortably for function. So in static procedures, the claw posture is reversed without restricting the functionality of the long extensors and flexors of the metacarpophalangeal joint. So flexion of the metacarpophalangeal joint will be possible, but extension will be blocked up to 20 degrees. So obviously, the static procedures can be done only if the passive flexion of the metacarpophalangeal joints or stabilization of these joints results in extension of the proximal interphalangeal joints, that is, Bouvier's maneuver positive. If there are extension lags of the PIP joints during the performance of this test, the use of a static procedure is contraindicated. Similarly, if there are fixed flexion deformities of the IP joints, these need to be corrected with therapy, splinting or surgical release before we can think of performing static procedures for these hands. The advantages of the static procedures are that they are simple procedures and the need for tendon transfer is avoided and the claw is corrected. Quite simple. But there are two main disadvantages. Firstly, the sequence of finger flexion is not corrected. In an ulnar claw, first the interphalangeal joints flex and finally the metacarpophalangeal joint flexes. This is against the normal cascade where the metacarpophalangeal joints flex and then the interphalangeal joints flex. The second disadvantage is that recurrence of the claw is possible due to stretch of the tissues over time. Now let us see what static procedures can be done. We know that we have to place the metacarpophalangeal joint of the involved fingers in 20 degrees of flexion. So looking at the tissues on the flexor aspect of the metacarpophalangeal joint of the finger, we find 5 important structures: the skin and fascia, the pulleys, the tendons, the joint capsule and the metacarpophalangeal joint as such. So each of these tissues can be modified as a static procedure to stabilize the metacarpophalangeal joint in 20 degrees of flexion. For the skin, fasciodermodesis can be done. On the pulley, A1 pulley release or pulley advancement procedure can be done. Tenodesis procedures can be done by modifying the tendons. The capsule of the metacarpophalangeal joint can be modified to do a capsulodesis. And finally, bone procedures can be done at the level of the metacarpophalangeal joint. Summarizing, there are 5 basic static procedures: fasciodermodesis, A1 pulley release or pulley advancement, tenodesis, capsulodesis, and bony procedures, and we shall see all of these in detail. First, fasciodermodesis. Basically, it consists of excision of 2 cm of palmar skin at the metacarpophalangeal joint level, with shortening of the pretendinous bands of the palmar aponeurosis also. The markings for this skin excision are made in this way. First, 1 to 1.5 cm is marked proximal to the web between the index and mid and between the ring and little. Then the radial and ulnar borders of the distal palmar crease. Now a 0.2 to 2.5 centimeters is taken proximal to the first point marked and the second point marked. All these points are joined to form an elongated or stretched horizontal hexagon. This is excised along with the underlying fascia and the skin is sutured without undermining the edges. And after suturing, the metacarpophalangeal joints of the fingers will be positioned at about 20 degrees of flexion. Postoperatively, a dorsal POP slab is applied for a period of about 3 weeks. We shall see the pulley advancement procedure next. The procedure was described by Bunnell way back in 1942. After making a transverse skin incision over the distal palmar crease proximal to the involved fingers, the A1 pulley system is identified and it is split for about 1.5 to 2.5 centimeters up to the level of the middle of the proximal phalanx. This can be a single incision or 2 parallel longitudinal incisions to even excise a small portion of the A1 pulley. This will result in a bowstringing of the flexor tendons at the level of the metacarpophalangeal joint, and as a result, when the flexor muscles contract, it brings about flexion at the metacarpophalangeal joints first, before flexing the interphalangeal joints. We need to remember that after this procedure, the range of flexion at the interphalangeal joints will also get reduced. Now we shall consider an important static procedure, the capsulodesis. And here we shall discuss 2 types of capsulodesis: the classical Zancoli's capsulodesis and the ulnar modification. The first step is to access and retract the flexor tendons after incising the A1 pulley. When the flexor tendons are thus retracted, we will be able to visualize the anterior surface of the metacarpophalangeal joint capsule, which consists of the volar plate also. This volar plate is incised longitudinally on 2 sides and also detached from the metacarpal to create a distally based flap. This flap is pulled proximally to bring about a flexion of 20 degrees at the metacarpophalangeal joint. At that particular point, a transverse drill hole is made in the metacarpal using a K-wire. The neck portion of the metacarpal over the transverse drill hole is also roughened. The flap of volar plate is now advanced proximally and attached to the metacarpal with monofilament wire passed through the tunnel. This repositioning of the capsule brings about a flexion of about 20 degrees at the metacarpophalangeal joint. This is done sequentially from the index finger to the little finger. Postoperatively, the hand is immobilized for 3 weeks in the same position with the dorsal POP slab, leaving the interphalangeal joints free. The ulnar modification of the Zancoli capsulodesis incorporates a small modification. The same advancement of the volar plate was done, but here a triangular portion of the deep transverse metacarpal ligament was excised on either side to allow for easier advancement. This modification also incorporated a 1.5 cm excision of the palmar skin and fascia, followed by immobilization for 6 weeks. As far as stenodesis as a static procedure for correction of the ulnar claw is concerned, there are many techniques. We shall discuss 4 of these techniques here: the Riordan static stenodesis, the Park static stenodesis, the Omer modification of the Park stenodesis, and the Fowler dynamic stenodesis. In the Riordan static stenodesis, the extensor carpi radialis longus and extensor carpi ulnaris tendons are split longitudinally throughout their length. One half is divided proximally, but the insertion is kept intact. The split portions of the ECRL and ECU are taken distally and volar to the deep transverse metacarpal ligament to be sutured to the radial lateral bands of all the 4 fingers. This suturing is done with the wrist in 30 degrees extension, metacarpophalangeal joints in 80 degrees flexion, and interphalangeal joints kept extended. This position is maintained for 3 weeks. In the Park stenodesis, free tendon grafts, either the palmaris longus or plantaris, are sutured to the transverse carpal ligament or the flexor retinaculum, then passed volar to the deep transverse metacarpal ligament and inserted into the radial lateral bands of the 4 fingers. In the Omer modification of the Park stenodesis, one tendon graft is sutured to the ulnar lateral band of the ring finger, passed around the deep transverse metacarpal ligament, and sutured to the radial lateral band of the little finger. Similarly, another tendon graft is sutured to the ulnar lateral band of the index finger, taken around the deep transverse metacarpal ligament to the radial lateral band of the middle finger. The Fowler's dynamic stenodesis is different because it crosses 2 joints. A free tendon graft is harvested and attached to the extensor retinaculum like this. These grafts are split into 4 and pass through the intermetacarpal spaces volar to the deep transverse metacarpal ligaments through the lumbrical canals. They are then attached to the radial lateral bands of the fingers. This dynamic stenodesis incorporates active wrist motion to tension static tendon grafts. Finally, we shall discuss the static procedures involving the bone and the joint. This could be in the form of bone blocks or arthrodesis. The principle of using bone blocks as a static procedure is that a dorsal metacarpophalangeal joint bone block is inserted to prevent complete extension of the metacarpophalangeal joint. Mikhail inserted the bone block over the dorsal metacarpal head, whereas Harvard elevated a bone wedge from the dorsal aspect of the metacarpal head to be used as a block. In extreme cases, arthrodesis of the metacarpophalangeal joint can be done in 20 degrees of flexion. However, this is quite disabling since there is no flexion or extension possible at the joint after the procedure.
I hope you enjoyed the video. I enjoyed making it. Please click on the shown links to see more about the ulnar nerve anatomy and the signs and tests associated with ulnar nerve palsy. And do not forget to subscribe to keep connected with the latest in learning hand surgery.